FG F23 thing.
Cloto. Cloto.
Yeah. That
Just say
was the
Cloto.
name.
You know it's FGF23, but just say Cloto.
Right. So she had to explain that to me. And I feel like I'm forgetting it, but I will get it.
You'll get, it's a very girl, Tiffany. It's not
Thanks.
hard. As I always say, it's just a matter of us trying to understand and grasp the concept of it because everything is a flow, even though we hear in here essay. The reason why I just said this use the term essay is because you're writing in paragraphs and you know it's like just a continuous sentences. So but it's points nonetheless and being able to explain. So it's not to get frightened when I hear. I see. Just joined in. Today you all will be telling me and explaining to me. I will not be explaining how that sounds. Because Saturday's exams and everybody's supposed to be at least, 50% prepared. 75% I should say. Prepared and now should just be the little touching upon edges. And
Yeah.
yeah. Like I only have one student in this class. Thank God for that student.
Afternoon, miss.
Good evening, Donovan. I thought I only had one student in my class, so now it's two. But I see 30 people online.
So then who am I?
Miss, I end up writing over the same thing again. It make a little sense there. It make a little sense to me now. I try this time. I really try this time.
You send
So,
it for me?
not as yet I will read it out so you will hear it. You want to hear it one time, miss?
Okay, so everybody,
Yeah,
Donovan,
write it.
Donovan is going to read. Donovan is going to tell us about diabetes and chronic kidney disease.
Mm-hmm.
So
Diabetes is
Donovan, you could
when
go
the
ahead.
body loses the ability to break down glucose. I try to be a little creative, so I write insulin is the transport for glucose, delivering it to the beta cells. When glucose can't get to the beta cells starve. Right? After that, I put there After that, I put there are two types of diabetes. Type 1 being juvenile diabetes or chronic autoimmune condition. When this happens, the body mistakenly attacks and destroys the beta cells in the pancreas that produces insulin. Type 2 is a chronic condition where the body either doesn't produce insulin properly or insulin resistant or doesn't produce enough insulin to keep blood sugars normal. In early stages of diabetes, nephropathy, Mr. Can you pronounce that? I have problems pronouncing that.
Diabetic nephropathy.
Right. In the afferent arteriole, it widens, which allows more blood to flow through the kidneys, causing hyperfiltration. With that happening, the kidneys become larger. The glomeruli also largens, increasing the area for filtration. When the glomeruli is overworked, it lets protein like albumin and large molecules to leak into the urine. Waste products like urea and creatine don't get cleared out, causing the thickening in the filtering membrane. Diabetes is a condition that can be controlled by lifestyle, diet, and medication. It is important to take care of your body. How that sounds, miss?
Donovan, I totally agree with you, right? Wait, let me just widen my screen here. Okay. Good afternoon to the people that just came in. So Donovan would have been telling us a little bit about diabetes and chronic kidney disease. And Donovan, yes, you did great, but you talk about the glomeruli getting weakened, right? But it didn't speak about that weakening of the glomeruli is also known as glomerulosclerosis, but it is a fibrotic thickening. All right, so you need to mention that there,
I will slip
right?
that in, miss.
Yeah, just add, you can just add it in. Um, Also, you mentioned hyperfiltration, did you?
Yes,
Or
miss,
did
I
I
did.
not? Oh no, I just asking, or did I just not hear? Because at that point, my laptop just went there. Um, okay, yeah, but you didn't mention the. Okay, yeah, yes. So yes, he did mention the hyperfiltration. He did talk about the mesangium. He did. It was the HbA1c. You didn't talk about HbA1c, Donovan, and that is one of the important details.
Miss, I
So you could
listen.
just,
But dogs when them making noise, miss, I listen, nah?
yes. So you you could put into the end, um, remember the blood cell dies after every 120 days, and the glycosylated hemoglobin is released, right? This is known as the HbA1c. So this is the shortened term for glycosylated hemoglobin, right? And this HbA1c levels continue to rise because remember, you don't talk about how the kidneys get damaged. You understand? So this HbA1c levels continue to rise, and with the body not being able to fight the glucose or control it, the diabetes worsen, causing the kidney disease, which is the diabetic nephropathy, you understand, to worsen, and this causes a cycle. And that's just it. So that's all the missing, Donovan.
Miss, I hope
So
I
I
too.
hope I hope that everyone who was listening, you all take little notes if you all was missing it too. Anybody else would like to add in something about diabetes and chronic kidney disease today? And as a matter of fact, every session is always an open session. You know, I always tell you all if I'm speaking too fast, It could slow me down because I know I'm a fast speaker, right? Every session is always an open session for anybody to talk. I doesn't like to call out on people because some people doesn't like that, you know. But I like to have, especially with this class before exam, I like to hear your point of views as students on the different topics. So that will give me uh an idea of where I stand with you guys also as a tutor and how I'm doing. Because sometimes I feel like, way boy, I just not doing good. Like, but my last class was excellent. I worked wonders, So
Miss,
if you all
ex-
if you are not communicating, I will know.
Miss, two things, right?
Yeah.
Somebody, I think there are people in the waiting room,
Yes, I'm alternating Mac joining, so I guess is joining.
and
Is Mac joining? Yeah.
the second thing is, could you explain the relationship between the high blood pressure and the RAS system?
Okay, so what you want me to explain? What you do? Tell me what you do not understand by the high blood pressure.
I understand the high blood pressure. I don't understand because most of what we're reading is um pointing towards hypotension and the RAS system, right? So the high blood pressure and the RAS system, we're not able to really grasp how it comes into play.
What the hypertension and hypotension is two different things.
Yes,
Hypertension is high blood pressure and hypotension is low blood pressure. So when you talk about hypertension and how that affects the kidneys, that's one thing. But then when the pressure drops low, yeah, that's when the RAS system comes into effect. So that's a different thing, I will say. So you put it together because the kidneys just get damaged and wouldn't be able to regulate the blood pressure. So therefore you could have either or, some high blood pressure or low blood pressure. One person could go like that. Sometimes you have a patient and they have high blood pressure, and then next thing you know it's because the pressure just dropping on you, you know. So
okay.
that's why I would say that put it
So
together.
the first with high pressure and chronic kidney disease would be that chronic kidney disease damages or affects the renal system.
Yes,
Okay.
don't worry, I will explain over the running system for you all. Right now, I saw some. Okay, so can somebody tell me how high blood pressure affects chronic kid? Well, that's my question. How is hypertension related to chronic kidney disease? I'm waiting. Someone, you can raise your
Um, I
hands.
I will I will read mine. I will read my essay on hypertension and CKD.
No problem.
Okay.
Yeah.
Renovascular disease is a reduced blood flow to the kidneys, which activates the RAAS, causing vasoconstriction that leads to hypertension. Hypertension is a persistently raised pressure in the blood vessels, and that has a two-way relationship with CKD, which means they make each other worse. Um, Hypertension causes damages to the blood vessels, which affects the kidney's ability to filter waste and fluids, which lead to a cycle of worsening kidney function and blood pressure control. This leads to a buildup of substances in the body, and over time, the damage leads to scarring of the kidney tissues. High blood pressure narrows the blood vessels, reduces blood supply to the kidney and damages the nephrons. Damaged kidneys cannot regulate the blood pressure. No, damaged kidneys cannot regulate the blood. Therefore, high blood pressure makes CKD worse.
Yes, Tiffany. Yes.
Well, that's all I have. Short, sweet, and straight to
Okay,
the
so
point.
yes, but before I continue, or before I say anything, I would like somebody else to give a point of view on the relationship between hypertension and chronic kidney disease. Or I'll just start to select people to call you and just randomly select people.
Okay, I'm gonna try.
Can I read mine?
No problem.
Sorry.
No, go ahead. Go ahead.
The relationship between hypertension and chronic kidney disease. High blood pressure puts extra force on the glomeruli, which is the tiny blood vessels within the nephron. Over time, the pressure damages the walls of the blood vessels, causing them to thicken and narrow. As a result, blood flow to the nephron is reduced, meaning less filtration of blood. Increased pressure scars the kidney, which is called nephrosclerosis, leading to progressive kidney function decline. The damage reduces the kidney's ability to filter waste and excess fluid from the blood effectively. Damaged kidney produce more renin, which is the hormone responsible for maintaining blood pressure. The elevated renin-angiotensin system stimulates the release of extra aldosterone, which acts on the kidney for the reabsorption of salt and water, leading to fluid and sodium retention. The retention increases blood volume and systemic resistance, raising the blood pressure. Hypertension accelerates kidney damage and worsens kidney function, making blood pressure harder to manage. That's mine.
Oh my God, that was good. Like, yeah, that was real good. Miss Nicole,
Thank you.
yes,
Yes, miss.
it was, and I hope everybody who was listening could, take points where you all would miss points. You all can take points because it's have nothing like anybody is wrong here. It's everybody giving their point of view in order for each other to understand, because what you wouldn't understand from one person, you can always understand from another.
Miss,
Teamwork make the dream work.
excuse miss.
Hi, Bashara. Good evening.
Can't hear that. I didn't use all them big words enough.
No. I really liked how Nicole broke it down, especially with when
Yeah,
coming
kind
to
of
the
break
damage
down
of the
big words and put
nephrons.
meanings next to it.
Yes, and this is how you just get a full 10 marks, because she actually really broke it down. Not everyone does break down things like that, right? Now, anybody else? Because now, hypertension is a big topic, kind of how, right? Now, yes, the essay is short and sweet on it, and it could also be longer.
Hi,
So,
Miss. Good night.
good night.
I just sent you mine by email, but I know you said it wasn't well last week, so I will read
Yes,
mine for you.
but okay, no problem. And so, okay, so I want to clear this up. So everybody that sends me email, what I just do is I just open the documents with Google Documents, right? Because I find it just be easier to do the corrections. So I just do the corrections in red and send it back. So if you open it on Google Documents, you will get it with the correction. I don't know if anybody ever open it back with Google Documents, or if I feel like sometimes I just write comments and reply, right? Also, so I don't know if you all just see it, but I probably was supposed to mention that before.
No, miss, I still waiting on a response.
Okay, so I look at it. But yes, the person that just said they wanted tell me about the relationship between high blood pressure and chronic kidney disease. And this is everybody chance that you all can tell me about it, and let us have some discussions.
Okay, miss.
I'm listening. Miss Rose.
Okay. Hypertension and chronic kidney disease have a complex bidirectional relationship. Both conditions share a common ground in the impact on the cardiovascular system, highlighting the need for a comprehensive approach to their management, with long-term uncontrolled high blood pressure causing damage to the blood vessels within the kidney. This damage disrupts the kidney's ability to filter waste and excessive fluid from the blood, leading to buildup of toxins and a decline in kidney function. The damage can manifest as reduced glomerular filtration rate, the kidney's ability to filter blood is impaired, increased protein leakage, damage to the glomerular capillaries, allow protein to leak into the urine, which is also known as proteinuria, is sign of early kidney damage and vascular damage. High blood pressure can cause thickening and stiffening of the blood vessels within the kidney, hindering the function. This damage can lead to scarring of the kidney, nephrocirrhosis. The relationship between hypertension and chronic kidney disease is often described as a cycle. Uncontrolled hypertension leads to kidney damage, which further impairs blood pressure regulation, creating a vicious cycle. This cycle can accelerate the progression of both conditions, including the risk of cardiovascular events and kidney failure. Conversely, CDK can have several mechanisms contributing, such as sodium and fluid retention. Impaired kidney function leads to the body's inability to effectively eliminate sodium and fluid, resulting in overload and increased blood pressure, activation of renin, adenosine, aldosterone system, also known as RAS. The kidneys play a crucial role in regulating RAS, which helps control blood pressure. CDK can disrupt the system, leading to increase in RAS activity and higher blood pressure. Endothelium dysfunction. CDK can damage the endothelium, the lining of the blood vessel, impairing its ability to regulate blood pressure. The relationship between hypertension and CDK is complex and bidirectional. Understanding this relationship is crucial for developing effective management strategies and preventing the progression of both conditions. Early detection and treatment of hypertension, along with careful management of chronic kidney disease, are vital for improving patient outcomes and reducing the risk of serious complications.
Nice. But you can remember all that?
Well, most of it, but I'll be able to put it in my way.
Nice. It was really informative. And I like how you put in you spoke about the nephrosclerosis that also, because this happens. But also remember that high blood pressure, um, it also is a risk, and it contributes to like left ventricular disease and angina pectoris. You understand these stuff. So when it affects so that is why when the high blood pressure affects the heart, it affects the blood flow to the kidneys. Just for those who didn't know. I'm talking, am correct? Or tell me if I'm correct or no. So anybody know what's angina pectoris?
Chest pain.
No, yes, it's chest pain, but is what has caused the chest pain? So what has caused the chest pain is because they don't have
Insufficient
efficient
blood
blood
flow.
flow to the heart muscles, not just to the heart, but to the heart muscle. You understand? So it does cause it has caused pain because it's having it have obstruction in the arteries. Yeah, yeah, you know.
because of the high blood pressure. So it's the same
It's
thing like
like
what is
something like
in the kidney, it's happening in the heart too. When your arteries, that arteriosclerosis, it is them thing does happen in the heart also. Them things happen in the heart also when the arteries start to narrow. Once arteries are arteriosclerosis, it's just that it doesn't happen like it doesn't be exactly like when it's happened, but like when it's having calcification, and it's a calcification in the in your arteries in your heart. You understand? It's a calcification in your arteries in your kidneys. You understand? Because
Then
remember,
me
it's the
say that,
same blood
excuse
flowing through it, and it's in your blood nonetheless. It is the high blood pressure that's caused is a risk factor for peripheral artery disease. Anybody can tell me what is peripheral artery disease?
Peripheral artery disease is like like swelling in the peripherals, like your legs and your hands and that kind of thing.
It's just no peripheral artery disease. It's just like what we was now talking about, right? The narrowing of the arteries. You understand?
There's those that don't supply the heart and the brain, right? There's others.
Yeah, yeah. It's like main arteries and stuff like that everywhere else.
Miss, excuse. So I simplify high blood pressure and CKD without using all them big words. I'm not gonna get my 10 marks for it.
No,
Because I went straight to the point.
no, if you don't use all remember send your a
Yeah.
voice note. Right. So we will fix that. Because if you don't know what you know, right? And you're just adding a few words here and there, don't sit today, it'll just be about sharpening up. So everybody like, okay, we're discussing this and you have your stuff in front of you. So you can just touch and add in whatever you need to add in.
Sarah, I could try.
Yeah?
Okay, so this is what I had, right?
Yeah.
RAS is the hormonal system that controls the blood pressure. When the barrel reflex is a short-term response to help the blood pressure, right? If it's not working good, but then the RAS is the long-term one, which is actually renin, just a minute, renin, angiotensin. Oh God, just a minute, I know this. Renin, angiotensin, aldosterone system, right? So if the pressure drops, or whether it drop or it goes up, then the baroreflex would do that if it's short term. If it's long term, then the RAS will kick in, right? And the kidneys from the afferent arterioles would get the juxta glomerular glomerular
Juxtaglomerular.
the juxta right glomerular,
Juxtaglomerular.
right? And that means it will filter. That's what it's filtered from, right? And if
Yeah.
the kidney will produce renin to help with the blood pressure. So they will detect the low blood pressure because of that, right? And the liver
Yeah.
will produce the angiotensinogen. When the liver does that, then you would get
Rebecca, wait.
angiotensin 1.
So wait, Rebecca, wait. So what you are explaining is the renin angiotensin aldosterone system. Let me just clear that part. It's not really. That's not high blood pressure, right? So continue.
Okay. Okay, so then you will get the angiotensin 1, right? Then you would get the ACE, which is the angiotensin converted enzyme from the lungs.
Yeah.
and then you will get angiotensin 2. When you get angiotensin 2, if the pressure, if you have low blood pressure and you want it to be high, right, you will let the angiotensin to do its job, where it would affect the body, causing the vascular constriction of the vessels, and
Vasoconstriction,
the
yeah.
right, of the vessels, and the kidney would reabsorb the sodium and the water, because so the water will follow, and then you will get the aldosterone produced by the adrenal cortex, the adrenal
Yeah.
cortex, and the pituitary gland will produce the antidiuretic hormones, which is the ADH, and that will cause more urine. So you have more, you'll keep more water,
Yeah.
and it will raise the blood pressure. But if you don't want to raise the blood pressure, well, then you will get is a receptor blocker. So then it wouldn't get the constriction vessels. It wouldn't get you constriction of the vessels. So then that would lower the pressure.
Yeah.
That's what I have so far on
Yes,
that.
but yes, no, that's good. That's good. What you have, you understand? You have all the steps, and I hope that you just remembering that. Big, but what you have there is not the relationship between high blood pressure and chronic kidney disease, right? Now, I'm not telling you you're wrong or anything like that. Way to feel know how, right? But I giving you
No,
the
I
top,
had,
the
but
heading.
that's the thing.
First is the
I
RAS
did the
system.
high blood pressure last time, right? And you said I was missing that part, so I went and did that part. I
We was
just didn't
doing
add the other part.
we had RAS system too. Yes, so we didn't have to add in all that into it. So just know it's separating. Well, the whole explanation from for the RAS system is separating, okay?
Okay.
You will
All right.
understand Saturday.
Okay.
Everybody will understand Saturday what I was trying to say.
Miss,
Yeah?
Miss,
Yeah.
could you explain the relationship between the juxtaglomerular and the macula densa?
It says it's basically the same as like the right that all of them just be right in the same area, which is right when you come in between the afferent by the afferent arteriole.
Yeah,
That's
but one does detect pressure and the other one does receive that information, yeah? Tell me if I'm wrong. And then that producing an end, yeah?
the juxtaglomerular cells.
That one does detect pressure. Well, like if the pressure low.
Yeah.
And then the denser macula densa is getting to play. Well,
Yeah.
from what I read.
Yeah, so it's all of them that's coming to effect one after the other. The macular density and then the mesangial cells and the juxtaglomerular cells. So it's like all of them just work together in a team.
Okay, man.
Because remember, it's not just the juxtaglomerular cells, it's the juxtaglomerular apparatus. You understand? That is a part of the kidney. You understand? And that part of the kidney is right by the afferent arteriole there. You understand? So it's the juxtaglomerular apparatus that is speaking about. And yes, it consists of the macula densa cells, the mesangial cells, and the juxtaglomerular cells.
So if you're writing, say you leave out one or the other.
Girl, you can put in anyone. It don't matter.
Okay.
The point is you mention it, or you could just say the juxtaglomerular apparatus.
Okay.
Yeah. So if you say the juxtaglomerular apparatus, you're talking about the tree, right? Because if you can remember the tree, you just say the juxtaglomerular apparatus.
Thank you.
You're welcome.
Yes, excuse.
Yes, Michelle, I see your hand up.
My hand hurting, man, holding it up so long.
Yes.
How you tell me to open the document with the corrections? What I'm trying to
Google Documents.
Google Documents.
Yeah, so when you get an email with Gmail, right?
Well, I didn't receive back an email,
Well, no, it's your same Google, well, your same message.
the
You
same
just
one.
open it using Google
Oh, okay.
Documents. It does mark right on the thing there, open with Google Documents, and you press open with Google Documents, and it does just be there with all the
Okay, so going to
correction.
send messages what I sent you and then I'll get it back. Okay, thank
Yes,
you.
you're welcome. Yes, so moving along, somebody had asked me, oh my God, just 1 minute. Wait, never go on. Okay, somebody had asked me to speak about cardiovascular disease
Mhm.
and chronic kidney disease.
Mhm.
So somebody could tell me the relationship between cardiovascular disease and chronic kidney disease.
Cardiovascular.
Anybody? I know yes, I am seeing Miss Nicole hand is up, but I would like someone else to take a go at it before we give Miss Nicole to go at it.
Mhm.
So I guess I'll be calling on people. Sarah Hussein, are you online?
EMS,
Can you tell me the relationship between chronic kidney disease and cardiovascular disease?
EMS. But
Thank you.
miss, I cannot
Yeah.
teach your whole essay, when you call it
There's
out. So
nothing.
explain.
There's nothing.
Uh,
You could still tell me. You could tell me. There's nothing.
all right, no problem.
And after Miss Viana will go.
All right. So cardiovascular disease is accelerated by dyslipidemia. Dyslipidemia is the abnormalities of cholesterol in the body. Chronic kidney disease causes a decrease in HDL, which is the high density lipoprotein, the good cholesterol, and an increase in LDL, the low density lipoprotein, which is the bad cholesterol and triglycerides. A decline in HDL increases the risk of heart disease. The uremic state is a proposed risk factor for chronic kidney disease as it correlates with blood pressure and total cholesterol. Also, high homocysteine levels increases the risk for heart disease as it causes injury to the lining of the artery, leading to plaque formation and blood clots, which affects the renal artery, affecting the kidneys, backing up the blood to the aorta due to the narrowing of the blood vessels. This causes the renal artery damage, arteriosclerosis disease. Yeah, that was basically what I had.
Nice. Right. I know once you have atherosclerotic cardiovascular disease, um or peripheral vascular disease, it is caused the buildup of the you don't put the buildup of the plaque formation, whatever, but the point is to continue to have the plaque formation continuing, you understand, causing the cycle.
Mhm. Well,
Um, Miss Miss Saint Rose.
Hi, Miss Sarah. And which one you said? Cardiovascular?
Yes, you were right, cardiovascular.
Okay. Sorry about the noise in the background, okay?
I hear no noise. Okay.
Okay. Patients with chronic kidney disease exhibit an elevated cardiovascular risk, manifesting as coronary artery disease, heart failure, arrhythmias, and sudden cardiac death. Chronic kidney disease causes a systematic chronic pro-inflammatory state, contributing to vascular and myocardial remodeling processes, resulting in arteriocystic lesions, vascular calcification, and vascular stenosis, such as myocardial fibrosis and calcification of cardiac valve. In this respect, chronic kidney disease mimics an accelerated aging of the cardiovascular system. Individuals have much higher likelihood of developing cardiovascular disease compared to the general population. Chronic kidney disease contributes to cardiovascular disease through various mechanisms, including endothelium dysfunction, inflammation, vascular calcification, and alteration in mineral metabolism. Albuminuria presence of protein in the urine is also linked to an increased risk of cardiovascular disease in chronic kidney disease patients. Managing chronic kidney disease and its cardiovascular complication requires a multi-faceted approach, including lifestyle modification, medication like MRAS, and potentially advancing imaging techniques. Cardiovascular disease can worsen kidney disease, and kidney disease can increase the risk of cardiovascular complication. Coronary artery disease is a major concern in chronic kidney disease, and it's increased with declining kidney function. CKD can lead to heart failure due to fluid retention, altering hemodynamics, and other factors. CKD can disrupt the heart's electrical system, including the risk of the arrhythmia. Chronic kidney disease patients are at high risk. Pardon?
Arrhythmia.
Arrhythmia. Okay, thank you.
Yeah.
Chronic kidney disease patients are at higher risk of sudden cardiac death, potentially due to the left ventricular hypertrophy.
Left ventricular hypertrophy.
CKD and albuminuria are associated with increased risk of peripheral vascular disease and also likely to a higher risk of aortic arrhythmia. In summary, chronic kidney disease and cardiovascular disease are closely linked, and the increase of cardiovascular disease risk in chronic kidney disease is significant. Cause of morbidity and mortality. Early and comprehensive management strategies are needed to address the cardiovascular complications of CKD and improve patient outcomes.
Yeah. You could remember all that? I ain't doubt it.
I just have to look at spelling and pronunciation. Well,
okay, so what were the spellings? It could also help you to remember if you take it and you're putting it down, like all the so you know that your your different diseases under cardiovascular disease, which will be cerebrovascular disease, peripheral vascular disease, and write them down in like a list, so you could also write it. If you write it about 5 times, you'll remember the spelling and the name too, and then you know which part to put it in and how to explain it. So that will help you to understand it better, also that you could remember. Because you have everything.
Yeah, I like to write too much. That's my problem because I short notes.
You never have nothing like writing too much. The more you write, the more you write is the more you show that you understand. Now remember, yes, all you're writing the answer to Dr. Michael, but you have to you have to be like you're writing to somebody who do not know what the hell you're talking about. So the more explanation is always the better. That is why with diabetes, we started when you said the relation between diabetes and chronic kidney disease. I just say an example, right? You didn't just say, okay, high blood sugar does make the kidney worsen and make it thicken and it does make a cycle. That's the reason why you're just saying that, because you have to explain more. So we start off by explaining what is diabetes, the different types of diabetes, what does have to work from what doesn't have to work. You understand? With high blood pressure, it's the same thing we do. So with cardiovascular disease, yes, it have plenty other diseases that manifest underneath it.
Right.
But if you able to explain them, why not? Because you helping the person who reading your explanation to understand what it is about. Because you remember you had to write like if the person do not know anything about this topic, so
Right.
you informing them.
Okay.
That's just like how I come to that and I asking you all, right? And I feeling proud to know that, there's some real good stuff going on. Yeah,
Mm-hmm. Understand.
So I feel like, yeah, I do some work, but if didn't tell me nothing and just staying quiet and nobody and no one, everybody don't know, then it'll make me feel like if me do no work in the past few weeks, and then Dr. Michael will feel worse. So when he reading them essays sometimes and he only see 4 lines, he want to see that he get her 2 marks and leave it. So, and just imagine if your paper only had 10 questions and you get 2 marks for all the questions and you only gonna get how much 20 marks that ain't no pass. Yes, I am going to go through the bone, Miss David, because another student also asked me to go through the bone. So that would have been my next topic. But I just want to clear up our cardiovascular disease. So we know that.
Sarah,
Yes,
Sarah, excuse. I want to read mine, please.
no problem.
But I think somebody wanted to read before me.
It's okay, go ahead. And
Oh,
and
okay.
and person just went, yes.
No, it had somebody else in the chat say
Me,
Medina.
I miss
Yeah.
yeah, Medina. Okay, so
Yeah.
allow me to read mine.
Okay.
Oh my God. I'm excited. I want to make sure, So let me
Yes,
start.
yes, Miss Medina.
Calcium. This one is anemia chronic, right? Mine is short and sweet, but you could tell me what I could add in.
Yeah.
Um, um, chronic kidney disease. Miss just know, Miss, let the person go and I will go after her. Please, thanks.
No problem. I could go.
Yeah.
All right.
Okay, Tiffany, you can
Um,
continue.
yeah. CKD and CVD are closely linked with each condition, increasing the risk and progression of the other, and leads to a condition known as cardiorenal syndrome, which is a dysfunction in one organ that exacerbates the other. With CKD, the heart has to work harder to get blood to the kidneys. CVD risk factors are altered by the uremic state of dyslipidemia and the amino acid homocysteine, where a buildup causes damage to the lining of the arteries, which leads to an increased plaque formation. CKD can also cause a buildup of calcium deposits in the blood vessels, causing them to become stiff and less flexible, increasing the risk of CVD. CKD advances the development of atherosclerotic cardiovascular disease, leading to heart attack and strokes. And if the kidneys aren't functioning properly, they can't effectively remove excess fluid and waste products from the body, which leads to fluid overload and heart failure.
No, that was very short and nice, right? So Tiffany, what Tiffany did there was stick to the point, right? And she didn't stray because she probably not able to remember every single thing. So she
I
stuck to the
remember
point.
everything.
Yes, she stuck to the point, which was like okay, the definition of cardiovascular disease, you understand, and showing exactly how it affects the kidney there. You know, well, especially because you mentioned the main points, which was like the homocysteine, the buildup of the plaque, the atherosclerotic disease, you understand? Which I believe that is one of the main points, the atherosclerotic disease. You understand? Because with the cardiovascular disease, they talk about it having ischemia, right? And the
That's the
ischemia
that's the
is
that's the transient ischemia attack or something like that, isn't it?
yes, yes,
That
because
that you're talking about the
yeah, you
temporary
start to have
stroke.
ischemia. Yes, but what is caused it
Okay,
is
great.
because they have ischemia in your heart, and what ischemia is it is an inadequate blood supply to your heart. So again, you're not getting sufficient blood flow. You understand? That's why ischemia is so this happens because of the plaque building up in the arteries, right? So you don't have enough blood supply. And that will just lead to the other diseases. So you end up with the cerebrovascular disease, peripheral disease. You understand? And everything continues. So it was because leading to high blood pressure. You have a dyslipidemia. The plaque continues to build up within the arteries, and not only arteries in the heart, but the arteries in the kidney also. Because if you have a reduced flow of blood to the heart, you have a reduced flow of blood to the kidneys. Because remember, the blood flow to the kidneys coming from the heart to the aorta. The aorta and through the renal artery, and you wouldn't be getting a sufficient supply of blood to the kidneys, and the plaque continue to build up, everything continue to worsen. So what Tiffany did, she really stuck to the point, and I really like that, Tiffany. You understand? And anyone who mentioned, if you
Thanks,
all
I'm so
want to
proud.
see the the meaning of homocysteine, you could find it. Oh my God, sorry, I come like Dr. Michael now. I was going to say page 71 of the handout, but I don't have the handout. You all have. But it's on the page with cardiovascular disease and chronic kidney disease, right? Where they speak about the homocysteine, which is an amino acid usually found in hereditary conditions that lead to an increase of coronary heart disease, usually at a young age, right? And it leads to increased level of homocysteine, right? It leads to the injury of the lining of the arteries, which leads to an increase of plaque formation and may also increase blood clots, right? Causing atherosclerotic cardiovascular disease could affect the renal artery and lead to chronic kidney disease and kidney failure or high blood pressure. So just by talking about that homocysteine alone, you understand, could give you a few marks. Because they still mention atherosclerotic cardiovascular disease. Everybody with me? So, Miss Medina, you ready to tell me about cardiovascular disease?
Yes, miss. My phone was giving trouble there. So the interconnected relationship between cardiovascular disease and chronic kidney disease. Everybody hearing me?
Yes, we are hearing you loud and clear, Miss Medina.
Cardiovascular disease and chronic kidney disease are major global health concerns. Both conditions coexist and accelerate each other's progression risk. progression. Risk factors for both conditions are high blood pressure, which damages blood vessels in both the heart and the kidneys, and diabetes mellitus that contributes to vascular damage, and promotion of both kidney dysfunction and heart disease. Dyslipidemia, high levels are LDL and low levels, LDL levels which contribute to atherosclerosis. I don't know how to pronounce that, and acceleration of
Wait,
both cardiac and renal
Miss
damage.
Medina, pause. You are going to pronounce the word atherosclerosis.
Atherosclerosis.
Thank you.
That was it then.
Yes. So what about the okay? So we're adding the homocysteine okay, because
Okay,
explain
miss.
what happened with atherosclerotic events. You understand that at this atherosclerosis, it could affect the renal artery. You understand, leading to uh worsened kidney
Ex-
disease. You understand?
Excuse me, miss.
Yes.
Somebody in the waiting room.
Yes. Now let me see here. Yeah. Yes. Okay. So now I don't have my book right now with me with my essay. Now I do not know how Miss Sarah got my whole essay, but she got it, and I say kudos to you. That was good. Um, but I like to, for those that really and truly don't understand the cardiovascular disease and you want to try to make it short and sweet, you understand? Yes, you will start by talking about how cardiovascular disease increases with chronic kidney disease. You understand? Because coronary heart disease, it have coronary heart disease, cerebrovascular disease, peripheral vascular disease, and heart failure. All these affect the kidney, right? And there are also risk factors. So when you have chronic kidney disease, it puts you at risk for cardiovascular because it have the high blood pressure and to me the high you can mention the high blood pressure because high blood pressure is one of the main things that does lead to atherosclerosis also. You understand? And not everybody will be able to remember all these big words like the peripheral vascular disease. You can remember if you remember PVD, try to remember them by the acronyms PVD, CHD, for coronary heart disease, as CV well it also as you can put CVD is also cerebrovascular disease, but say what? So moving forward now, I would like to talk about bone metabolism. What was the question about secondary hyperparathyroidism? Well, I just told you all right about secondary hyperparathyroidism.
Miss, what was the question?
Excuse?
What was the question?
I said if last week, did I tell you all to read up about secondary hyperparathyroidism?
Yes, I did.
Yes, and Dr. Michael also did it with you all, and bone metabolism.
Go and get some trouble. I I did some secondary hyperparathyroidism. So nobody understand the bone at all. Oh,
Sarah, I understand it a bit.
yeah.
Okay, so adiosis is where the when the GFI drops, right? That's the glomerular filtration rate drops. The phosphorus will build up in the blood. And when the phosphorus builds up in the blood, the calcium will go down. The calcium will decrease because your body might not absorb the calcium in the GI tract. So you will have less absorption. Or maybe you're probably just not taking enough calcium. And when that happens, then the parathyroid hormone would they will send a message to the hypothalamus in the brain that will send a message to the anterior pituitary gland that will also send a message to the parathyroid hormones, one of the four parathyroid hormones, and they will get vitamin D from the bone. So the osteoclast will dig into the bone and get some calcium for the body. But when this happens, that will also damage the body in the sense that you could get bone disorder. Or you could get bad bone formation because it will also weaken the body. So what you could do for treatment is you could probably get like a vitamin D. You could get vitamin D supplement or a calcium supplement. In some cases, they also do a parathyroidectomy where they can probably remove part of the parathyroid gland to help it. And that's what I have.
So yes.
Miss, could I read mine?
Sure. Yes, Rebecca. Yes, Rebecca. You had point. Yeah. You had points. You understand?
Before you read, I did just hope.
Who's speaking? I have two people, mic on, and I also trying to speak, so I don't understand. Okay, so Vanessa, yes, you had the points, but I would have liked to hear you speak about the conversion of the vitamin D. You understand?
Miss, that wasn't me that was reading. I just trying to ask a question.
Yes, I know, but I was just referring to Rebecca, the person who had just explained the bone disease, right? So two persons' mic was on at the same time that I was speaking, and that is the reason why I muted everyone, because I didn't know who was speaking. I also asked who was speaking, so I just continued. So the person who was speaking can continue to speak now.
Miss, the person that was just reading, she said the vitamin D, correct me if I'm wrong, comes from the bone. Is that correct?
No.
No, it comes from the liver, yeah?
Excuse?
Where it comes from?
Yes, get vitamin D. It is absorbed.
Right. From the intestine.
Excuse me. Yeah.
Yes, or from the sun.
Right.
Right.
That's my question.
So yes, because
I heard her said from the liver. I heard her
that's why I said she
say
could explain the vitamin D better.
from the bone. She said from bone. That's why
Is there a question here?
No, I wasn't hearing her properly all the way, but I picked up a few. Yeah, but I was making the correction. So
Sarah,
yes, listening, Brandon.
Brandon here. Is the vitamin D, right? Is it converted due to the sunlight or it's absorbed with the sunlight?
No, it is absorbed, and well, now remember, vitamin D is what you call That's not it's calcitriol resulting in high and low calcium and hyperstenosis. So the CVF takes place in active and hypothalamus.
Sarah, that is talking about
Calcitriol is right.
where calcidiol is changed to calcitriol by
Yes.
the absorbed. Yeah, I forget that part.
No, I have it right in front. I have it right in front of me, but I'm looking for something what I wrote. Apparently, I read in the wrong page. Yes. Yeah, so you get the calcium, the vitamin D from the sun, or it is ingested through the intestines. You just mostly get vitamin D from plants. You understand? And this raw form of vitamin D is what we call ergocalciferol. Everybody with me there? And for the vitamin D, which is ergocalciferol, for this to become active, you understand? It needs to be converted to cholecalciferol, which is calcitriol. You understand? And this is what stimulates for the body to absorb the vitamin D from the intestine. Well, how it does go for the absorption of the vitamin D, because it's not like it just get the vitamin D and your body just takes it in. It has to be converted in order for it to actually be absorbed into the body.
Sarah, excuse me.
Yes?
Just to clarify, because I hear you say something and it kind of was a little bit off as compared to what Dr. Michael had said. I know you said
Okay.
vitamin D is ergocalciferol, right? But I think he said that vitamin D2 is
It's
ergocalciferol.
ergocalciferol.
Yeah, but you just say vitamin D, yeah, you didn't say vitamin
Oh,
D2. So that's why I was a
cal-
little bit confused.
oh, vitamin D
Because
is calci
vitamin D and vitamin D2 is two
calcidiol.
different things.
Yes, but it's vitamin.
Right.
S is like vitamin D1, vitamin D2, vitamin D3 because it does be mixed up. So the vitamin D1 will be calcidiol.
D2 is calcidiol and D3 is calcitriol.
Right, and normal D1,
So,
which will
so,
be ergocalciferol.
so is it that the vitamin D just go to the bloodstream and then it would go to the liver to form vitamin D2?
Yes, to get converted and then to vitamin D3, because remember that is what does promote the absorption of the calcium. Yeah, for your body you need vitamin D for your body to absorb calcium. Right?
Yes.
Right. So we have to establish that we understand that you need vitamin D for your body to absorb calcium.
Okay.
You understand? So yes, the calcidiol, right? Well, the ergocalciferol. Monsieur could tell the ergo. E ERGOCALCIFEROL. Ergocalciferol. What's that? Somewhere else, boy. That's what one thing, right? I have this.
Right. Second, please. Okay. Mm. Okay, yeah. So I found that answer, right? So vitamin D is synthesized in the skin by the action of the ultraviolet rays on the skin or ingested in the diet and then transported to the liver. So I know I took a little while because I know it was like right here, but I just wanted to get it right. So vitamin D is synthesized in the skin by the action of the violet rays or ingested in the diet and then transported to the liver. So if you know everybody, they know you don't want to write all them big words. Yeah, you know, you could just write that you could absorb vitamin D from the sun or you could digest it while you eat. I try to make things simple for the ones that not going to remember all those big words. Right? So when this vitamin when you eat this the vitamin D or you ingest it through the sun, right? It's synthesized in the liver. So in the liver, it is then converted only after you ingest it, right? Then it is converted, Tiffany, I hope you listen to this one. Then it is converted to the ergocalciferol, which is the D2. So calciferol is the D2. Apparently it was not D1.
Right. So that's what I know.
But
Because I know that's
but
what
it is
Dr.
also
Michael
called
said.
calcidiol. So that's where it was getting
Yeah.
mixed up with.
No. I know that the ergocalciferol and calcidiol is the same as D2. I know that. But what I needed clarification on, because you said that you was just saying vitamin D now, and for ergocalciferol, and Dr. Michael was saying D2. So
Yeah.
that is what I needed clarification on. So it's D2.
Yeah, so when you absorb when you get the
Okay.
vitamin D from either the sun or ingested, you're just saying that is D1, right? We name in the
Mm-hmm.
phases D1, then it goes to the liver and it gets synthesized into D2,
So
which is
D2
ergocalciferol,
for all. Mm-hmm.
also known as calcidiol, right? And that
Mm-hmm.
vitamin 2, it is stored in the liver and then it could be converted to vitamin D3,
Miss Excuse.
which is calciferol. Yeah.
So the enzyme, the fibroblastic growth factor, right? That is FGF23. And that
Yeah.
is the enzyme that inhibits and that converts vitamin D2 to vitamin D3.
No. That's Clotho have to do with phosphate. So I don't want to mix it right now. So I don't want to mix it up because it's like a step process. Because when you talk about the vitamin D, and then we start to talk about how when the kidney is not able to
to work properly, this has become affected, and then you'll see where the decrease in the calcium comes in and the increase in the phosphorus.
Let's excuse somebody in the waiting room.
I see nobody in the waiting room. There's nobody in the waiting room. Andre is not in the waiting room.
Miss, I could read minds so I could get my correction one time.
Okay, no problem.
Okay. Bone and its relation to CKD. Chronic kidney disease affects many organs in the body. One of the major complications is a mineral and bone disorder. CKD and MBD represents a group of related bone metabolism and mineral homeostasis. This condition
Homeostasis.
homeostasis. This condition significantly increases the risk of bone fractures, cardiovascular disease, and mortality. Healthy kidneys maintain calcium phosphate balance. Phosphate balance. They produce active vitamin D, which is calcitrol, which is essential for calcium absorption. Parathyroid hormone regulates calcium and phosphate by acting on bones, kidneys, and the gut. But bone undergoes constant remodeling, a balance between bone formation, osteoblasts, and reabsorption, osteoclast. As CKD progresses, kidney function declines, leading to phosphate retention and reduced calcitrol production and secondary hyperparathyroidism.
Okay.
Anything I have to add in?
So as I was going along, I was, yes, the vitamin D conversion, and because I'll say, Dr. Mike, I would like to hear about like what we're now talking about, how it goes to the liver and converts and stuff like that, right? And then we'll come along to the fact that when the kidney function declines, you understand, this vitamin D3, right? It does decrease. Okay, so I now see Andre join the waiting room. So vitamin D3 does decrease, right? Everybody with me, or everybody lost? So I'll just start over.
Vitamin D3 does decrease what?
It does decrease with the kidney function declining. Tiffany. When the kidney function declines, the level of vitamin D3 also decreases, which is the vitamin D3, which is calcitriol. It decreases. Yes, good evening, Andre. It is nice having you. We are speaking about bone and secondary hyperparathyroidism, bone metabolization and secondary hyperparathyroidism. So we started off by talking about vitamin D, right? And how it is ingested, and how vitamin D is synthesized through the skin and also ingested through the diet, right? And after it is ingested, which we call as vitamin D1, you understand? After it is ingested, it goes to the liver and it is then converted to ogocalciferol, or which is vitamin D2, also known as calcidiol, right? And this vitamin D2 is then converted, right, to vitamin D3, also known as calcitriol. And this is the active form of vitamin D. So only when it reached the D3, then I will say it becomes active. You understand? But you have to also mention that the conversion from D2 to D3 is promoted by the enzyme, the 1-alpha hydroxylase. Right? So when you have any conversion of D2 to D3, right? So when you're converting from ergocalciferol to calcitriol, right? Or you could what's the next name for ergocalciferol? Anybody?
Calcidiol.
Nice. So when you're converting from calcidiol to calcitriol, what converts this calcidiol to calcitriol is the enzyme called 1-alpha hydroxylase. What? And as your kidney, as a kidney function deteriorates, so your kidney function declines, right? The level of vitamin 3, which is calcium.
Calcitriol.
Okay, thank you very much. This also decreases, you understand? And remember, this vitamin D3 promotes the absorption of calcium and phosphorus from the intestines, right? So if your kidney is not working properly, then you're not going to get enough vitamin D3, and then you will have a problem. And the problem will be you won't be able to absorb calcium and phosphorus from the intestines. Is that correct?
Miss, I think the part that confusing everyone here, I have it in the handout here. The
Mm-hmm.
FGF23 inhibitor inhibits the enzyme that converts vitamin D2 to vitamin D3, which is 1-alpha hydroxylase, also leading to the decreased absorption of more phosphate from the intestine. I think that's the part what's confusing everyone, where the 1-alpha hydroxy hormone also plays a role in the conversion of the vitamin D2 to D3.
Okay, because that is the enzyme, the 1-alpha hydroxylate is the enzyme that's responsible from D2 to D3. So if the FGF23 is what?
Where's that, miss?
I still don't understand your question, but you can repeat it for me, please. With
No, it's
just the
not.
part of the FGF23.
It's not a question. In the handout, we have the FGF23 inhibits the enzyme that converts vitamin D2 to vitamin D3, which is the 1-alpha hydroxylase, also leading to the decreased absorption of phosphorus from the intestine.
Mm-hmm.
I think that part in hypo class, I believe, which was confusing everyone with the conversion of vitamin D3, D2 to D3, I think.
Yeah, but it doesn't come to FGF23. It inhibit that conversion and whatnot. But it had to do with the decreasing of the kidney disease.
Right.
Okay, let me read that part of the handle because I didn't have my hand just on. Right, so remember it was they mentioned the parathyroid hormone stimulates the digging of calcium from the bone, and this is done by the cell called the osteoclast, right? And then further down it says that the osteoclast digs out calcium from the bone, right? And there is a substance called FGF23, which is fibroblast growth factor, which is secreted by the osteocytes in response to elevated calcitriol. Because remember everything imbalanced, you understand? So when the osteocytes start to dig out the calcium from the bone. This does come into play because the osteoclast and osteocytes, they're working. You understand? Because remember, your body can't produce, it's like your body can't produce no calcium because the vitamin conversion, the conversion of the D2 to D3 is affected. You understand? And when you have chronic kidney disease, right, they talk about the FGF being increased and promotes the excretion of phosphorus in the urine. Because remember, your phosphorus could be building up inside because you have chronic kidney disease and you're not able to have the whole conversion. So this coming with like a whole feedback system, right? Because the parathyroid hormone coming into play. So that's why I was doing it from the vitamin D, because you still have to understand it from the vitamin D, right? And yeah, the reason why I'm doing it so because it would be expected. This the explanation. You understand? So we know that the calcitriol, which is the vitamin D3, right? This does promote the absorption of the calcium and phosphorus from the intestines. So I come straight back to that because it's all related, but it's a story. Well, I say it's like a story because from one thing to the next, and you have to understand one part to understand how the other part works. So you're not able to get vitamin D, that means you're not able to get calcium, which means that the calcium will have to you have to get calcium from somewhere else, which means that your bones will start to dig it out. But how this happens, we know that is the basic explanation of it, right? But how this happens, right? How when we have a calcium deficiency, what happens, right? So when we have a calcium deficiency, it have an increased level of phosphorus in the blood, right? And when it have a increased level of phosphorus in the blood, a message is sent to the hypothalamus in the brain to secrete the parathyroid releasing hormone. And now I would like for you all to remember this especially. If you want to write it down like if it's a flow chart, you understand? Do it, write it. You don't have to write everything, but once you is the words, the explanation will come to you, and you will remember. Everybody lost, so everybody with me
We here.
so far. In explaining this. Excuse?
You're coming too fast.
I went too fast.
Yeah.
Okay, so let me just explain it over, right? So vitamin D, which we said D1. Before I continue, I will say D1, D2, D3, so that you'll remember that is 3 steps, right? So vitamin D1, as we will call it, yeah, we can get vitamin D from the sun. It is ingested through the ultraviolet rays on our skin, or we can get it from from digestion, right? When we digest this vitamin D, it is um it is ingested and it is transported to the liver. And in the liver, it does get converted to ergocalciferol, which is vitamin D2 or calcidiol. I always like to use the word calcidiol because I find it's a shorter word to remember. You understand? And then it does also rhyme with calcitriol, which is vitamin D3, right? So we have this conversion of vitamin D in the liver to vitamin D2, you understand? Also known as calcidiol. And it is converted to vitamin D3. You understand? It is converted to vitamin D3, also known as calcitriol, right? And calcitriol, this is the active form of vitamin D. But the enzyme that is responsible for this conversion of vitamin D2 to vitamin D3 is called 1-alpha hydroxylase. So when we have a dysfunction in the kidney or chronic kidney disease, or the kidney functions starts to decline, right? The vitamin D3 also declines, right? Because we have a decline in the level of calcitriol. And what calcitriol do is it does promote absorption of calcium and phosphorus from the intestines. So if you have a problem with your kidney, then you have a problem with the absorption of calcium and phosphorus from your intestines, right? You cannot, it cannot happen because your vitamin D3, that enzyme that converting D2 into D3, it's just not working. So that chemical reaction is not taking place in your body. So when this happens and it have a calcium deficiency, it does have an increased amount of phosphorus. So we have low calcium and high phosphorus in the blood, right? And then a message is sent to the hypothalamus. Where's the hypothalamus? The hypothalamus is in the brain. So a message is sent to the brain, right? To secrete parathyroid releasing hormone. And this parathyroid releasing hormone, it will then go to the anterior pituitary gland, right? Also located in the brain. So from the hypothalamus to the anterior pituitary gland, right? So hypothalamus, parathyroid releasing hormone, because you know that the hypothalamus, it have to secrete the parathyroid releasing hormone, and this parathyroid releasing hormone does go to the anterior pituitary gland, right? And this anterior pituitary gland, which is your pituitary, you can just put your pituitary gland, right? It releases parathyroid stimulating hormone. And this parathyroid stimulating hormone does go to the parathyroid gland and stimulate this parathyroid gland, right? And we know it have 4 parathyroid glands. And which part it is located?
In the neck.
Nice. And the parathyroid stimulating hormone, it will stimulate the parathyroid gland to release parathyroid hormone. And that is how it is get parathyroid hormone. But with the high levels of phosphorus and the low levels of calcium, right, that this patient with CKD have, now you're studying how to increase your calcium, because you can't get no calcium, you understand, because your body not able to convert the D2 into D3, so you can't get no calcium, and you have a whole set of phosphorus build up in your blood. You understand? Because remember, when your calcium start to drop, your phosphorus start to go up. Everybody with me so far? Understanding the process that we make here to how you're ending up with bone disease. Okay.
But I was just wondering that the explanation for this, and well, except for the vitamin D1 and D3 and whatever, secondary hyperthyroidism has a similar thing, because it has the calcium, the reabsorption, the
Yes, and everything is one. Everything is one, because how you reach the secondary hyperparathyroidism, and the story starts from the fact that your body cannot absorb the calcium, because that's how the parathyroid hormone end up being released for you to end up with secondary hyperparathyroidism, because all these all these things is like a whole chain reaction that makes it. So yes, it is related. Now, you will understand why I'm saying it is related. I'll continue to say it is related only when I get the exam paper and then you'll see what I was talking about. But I ain't just telling you all this because I want to talk or because I just want to explain something. You understand? It's because I really wanted to understand it because when I get questions, you have to know how to answer it because questions just come tricky. And you will need when explaining, especially for the secondary hyperparathyroidism, you will have to explain how it come into play, and how it come into play will be with the vitamin D. You understand? And also with the bone metabolism. That's with the osteocytes and the osteoblasts making, and digging out with the calcium and whatnot. But it have a reason behind everything. It's just a matter of you being able to read the question and put what where.
So
You
most
understand,
of
Miss
the
Rose?
time would be acid.
Excuse?
The other exams would be essay type as well.
Girl, every exam is essay type. Get used to it. This is the worst exam yet.
Hmm.
Right? And
Okay.
now, yeah, it's essay type question. So what? Like every time a student hear essay, they just get frightened. I just realized that for my own self. So what if they say essay type? They say explain something. So when you see the word explain, you have to talk about everything about this topic. So they talk about secondary hyperparathyroidism, right? You ain't just going and only write about the point what secondary hyperparathyroidism is, because then you'll just get a 1 mark, especially if it's a 10 marks question, right? It's obvious you have to start off with how the secondary hyperparathyroidism even comes into play, which starts from the vitamin D. With the vitamin D. You understand? Okay. Oh. Yeah, so everybody understanding or are confused or what are we standing at? What's the point that we're standing at right now?
Which the stimulating hormone releases parathyroid hormone.
Okay, so continue. Yeah, so how I will explain that secondary hyperparathyroidism comes into the play, you understand, is because it is subsequent to the cause of something else. You understand the fact that it have too much calcium in the blood. I mean, sorry, too little calcium in the blood and an increase in phosphorus. You understand it? All right, it makes the brain stimulate this parathyroid hormone, you understand, and then you end up with an increased amount of parathyroid hormone. So I have a patient and his parathyroid hormone is 1,061, right? Now that's real high, and he's be complaining about he bones hurting him and he back always hurting and stuff like this, you understand? Because why? The
Miss
osteocytes they're digging out his bones, you understand? Because the body start to feed off of his bones so calcium, right? Now, I could also tell you all a real life situation, right? That I saw with a patient. She had osteomalacia, right? And she had the same thing. Her parathyroid hormone was really high because her calcium was really always really low. You understand? And the when she had a graft, if she had a graft in one hand, one day she came to dialysis, and when they was going to cannulate her, her hand broke, right? So now this woman had a very loving husband, and her husband decided to carry her to the fix the next hand with a fistula, and they gave her a catheter. Now she was walking. So over like the next 2 months, she came in wheelchair. How she ended up in wheelchair is because she didn't fall down and break she hip. She hip break and she fall. You understand? Because the osteocytes and all this osteoclastic behavior that's happening due to the fact that her kidney disease was really bad and her body was unable to to do that conversion. You understand? So therefore she was not able to get enough calcium. So now the only way for the body to get calcium is because it's digging out from the bones. You understand? And yes, Donovan, the bones become what we call brittle. You understand? Because your own is like your own body eating your own body. Your body eating your own body. You understand? And the bones become brittle, and her hips broke. She was in a wheelchair. One hand now coming in from a healing. You understand? And the next sad part is when the graft developed on the other hand, which was another access for we to get her blood, the hand break another day. Right? So the new hand with the fistula break, and we can't use the hand what did break before because the fistula get damaged when the bones broke in that hand, right? And this next hand, the hand broke in 3 different places. The shoulder, a little lower from the shoulder, and by her wrist. So these things does be happening in real life. Of course, the patient died, right? May her soul rest in peace, right? But that's just to show you that it does really happen in real life instances. And me seeing that, it was really sad because to me, I find it's like just suffering, you know? So, with the increased level of parathyroid hormone, you understand, stimulated by this process called secondary hyperparathyroidism, right? You,
Miss Excuse.
yes,
So is it safe to say that the secondary hyperthyroidism is not really because of the disease itself, but is because of the overproduction of the
yes, yes,
parathyroid hormone?
yes. That is it. That is exactly it, and that's why we're trying this. Yes, that is why they call it secondary hyperparathyroidism, because it is secondary to something happening. It is because it have an overstimulation of the parathyroid hormone due to the chronic kidney disease.
Yeah, the parathyroid damage overwork.
Yes, because remember with the chronic kidney disease, your body cannot do the vitamin 3 conversion, the vitamin
Right.
D3 conversion. So then
Build up in it.
the calcium decreasing because the body not able to absorb calcium. Because remember, this is what the vitamin D3 does do. It does make your body absorb the calcium, right? And with your calcium, being low, your phosphate does start to go high,
Right.
right? And when your phosphate starts to go high, then your brain you start to get this the messages sent to your brain, to the hypothalamus, right? And this the hypothalamus in the brain does secrete the parathyroid releasing hormone, right? The hypothalamus in the brain, right?
Because all the brain is
Yeah.
because all the brain is getting the message is that the calcium is low,
And
but
the
they don't know
phosphorus is high. Not just the
phosphorus is
calcium is
high.
low, but the calcium is low and the phosphorus is high.
Right.
That is what the brain gains the message. Yes, you're correct.
The parathyroid hormones and
Mm-hmm.
at no so it doesn't have no level to say, well, this
Stop.
and that
Yeah.
stop.
It's on level to say
This
stop. Yeah.
so there will be a overproduction of it, and that is
Right.
how I
The
get it.
secondary hyperparathyroidism come into play. So yes, that is why they call it secondary, because it is okay, that is like it's a chain reaction or something else. That is like I in a fight, but you come and buy over the fight. You end up in the fight because of me, so you was a secondary effect to the fight. You wasn't the main point of the fight. You understand? So they call it secondary because it is, and it's right there in the handout. Let me see if I find out. The reason why we say secondary hyperparathyroidism is that increased parathyroid hormone levels has resulted and is secondary to something else, which is the low levels of calcium and the high levels of phosphorus. So, when this parathyroid hormone starts to come into effect, right? It's telling you, well, okay, look for calcium. Your brain telling, but yeah, look for calcium because we ain't getting none. You understand? It's like your brain having this conversation. Yeah, look for calcium because we ain't getting none. Oh, the bone is made up of plenty calcium. Why don't we start to take calcium from that?
Right.
You know? And then it does that is that is where it does stimulate um the us let me make sure I'm telling you the correct thing.
Osteoclast or the osteocyte
Yes, the
to dig.
osteoclast. You understand? That's where
Yes,
they stimulate and they start to dig to dig out the calcium out of the bone. You understand? So that is where we come along. When the osteoclast start to dig out the calcium from the bone, it have to say there is a substance called FGF23, which is fibroblast growth factor, right? Which is secreted by the osteocytes in response to the elevated calcitriol, right? And the levels of FGF23 are increased in early chronic kidney disease and promotes excretion of phosphorus in the urine. So, with the osteocytes being active, I should try to put it like that. You understand? In the response, you understand? It does it has made the phosphorus become be able to pass out through the urine. You start to see it because why? It have a high level in the blood. So instead of a high level in the blood, you have a high level in the urine. And it being
and
pushed out. Who else want to speak?
no, I say because the kidney is already damaged. It is not filtering properly.
Yes.
So the high level of phosphorus will end up in the urine.
Mm-hmm. Because remember, um this this FGF23, right? It does
And
inhibit the enzyme that does convert the D2 to the D3. You understand? And this does also lead to the decreased absorption of phosphorus from the intestine. So that is how that is when that's how the phosphorus will continue to be elevated, right? And when the phosphorus continue to be elevated, right, the parathyroid hormone continue to be getting this message to secrete more parathyroid hormone, you understand, and the calcium continue to get dig out from the bones, and that is when you continue. That is when the secondary hyperparathyroidism start to get worse. You understand?
And the bone will decline health earlier.
Yes. And but we'll start to get so now we're seeing where the secondary, now let me see how the secondary hyperparathyroidism does affect the person, because we established how the secondary hyperparathyroidism come into play, right? So we know that the parathyroid hormone increases the amount of the calcium in the blood, because it does cause the osteoclast to start to dig out. So that now the osteoclast digging out all the calcium out of your bone and into the blood, right? But when it have too much of calcium in the blood, this has become dangerous, right? And why? And what we just call too much calcium, high levels of calcium in the blood.
Hypercalcemia.
Yes, hypercalcemia, right? And when we have high levels of calcium in the blood or hypercalcemia, this could cause calcium to be deposited into soft tissues in various parts of the body, right? And when you say various parts of the body, this also means the heart, you understand? And the heart have the aorta and it have the aortic valve, right? So this calcium starts to it building up in the blood, you understand? And it passing through the blood had to pass through the heart. So that is how it starts to build up in the aortic valve, right? And then we could get that's how we just get calcific aortic stenosis. So secondary hyperparathyroidism could lead to aortic stenosis, right? Calcific aortic stenosis. Because the secondary hyperparathyroidism, it causing the too much the parathyroid hormone in the blood, causing the bones, the calcium to be dig from the bones. And if this continue, because the brain, remember, the brain not telling this hormone to stop, because it don't have the high the signal of the low calcium and the high phosphorus, because your body not producing the D2 to D3, not converting it. So it don't have no way your body can get the calcium, and your brain not stop and send this message, right, to stop produce this parathyroid hormone. So it starts to get worse now, right? And you just continue to get more calcium in your blood. And when the calcium continue to build up in your blood, it starts to, just like with atherosclerosis disease, where it had the narrowing, you understand? The calcium start to build up all around the walls of the aorta, and it start to damage the aortic valve, causing aortic stenosis, or calcific aortic stenosis. You all understand that?
Mm-hmm. Yes, ma'am.
And when you have this calcific aortic stenosis, which does the which makes the aortic valve impaired, you understand, we wouldn't get a normal circulation of blood to the left ventricle. Remember, the aortic valve to the left ventricle, so now we have a slowdown in the production of blood to the left ventricle.
Miss, that would cause hypertension.
Yes, them thing will cause hypertension, atherosclerotic disease, it causing peripheral disease, it causing heart disease. So now let's see how everything does just be problems and everything is connected, but it's a matter of mixing them up. Because that's why I just say it could be short or it could be long, because it's a real plenty topics to write about in everything, and you could include everything in everything. It's just a matter of mixing up the topics and getting everything to the point that it needs to be. So that's why when I start, excuse?
When I just try to envision it now. So I see the hypertension and then I see the RAS system coming into play because of the hypertension.
Yes. So the last say it's a matter, you're not mixing up everything, but having everything to its own subgroup. You understand? It's like you're talking about bone. When you're talking about oh God. Yeah, when you're talking about bone and secondary bone mineralization and secondary hyperparathyroidism, you understand? You're talking about the parathyroid hormones. So we know we're dealing with the brain and we know we're dealing with vitamin 3. So that is where your topic will stand. You know, when you're talking about cardiovascular disease, you're talking about heart disease and the disadvantages that it's having on the chronic kidney disease. You know, that's when you're talking about hypertension or high blood pressure. You know, we're talking about how the nephrons being damaged by the constant high pressure, and it will continue to get wear out. You know, when you're talking about diabetes, we're talking about the pancreas mainly. You understand? You're looking at what it mainly connected to and making that your big topic. So that's how you divide your chronic kidney disease into subdivisions, but all have different relations, yet still all are related and all will affect each other. Understand?
Yeah.
Nice.
Yes, miss.
So now that we have secondary hyperparathyroidism in play, you understand? It's digging out all the calcium out of your bones, you understand? And the calcium in the blood start to get too high, right? Now this calcium start to go to your little soft tissues and it start to go into your arteries, you understand, and different parts of your body, but it's really dangerous when it reaches to the aortic valve, because this is in the heart, you understand, and you start to get this cause calcific aortic stenosis, right? And this could interfere with your blood circulation, right? So we'll try to right now we're wondering, okay, how we'll avoid all this happening, you understand? How we could prevent the calcium from being so high, you understand? Because we cannot continue to have hypercalcemia, because if we have hypercalcemia, well, then we'll end up with aortic calcification, you understand? Aortic stenosis, right? So to balance this hypercalcemia, or to try to fight this calcium from being high, you understand? We have a hormone called calcitonin, right? From the thyroid gland. Now, don't get mixed up the parathyroid gland and the thyroid gland. They're two totally different things. Right? So we have a hormone called calcitonin, which comes from the thyroid gland, that helps us to fight hypercalcemia, which is high levels of calcium in the blood, right? And it'll send down the levels of calcium in the blood. You understand? The calcitonin. So look at it like this. Just like how they say body toning, right? Yeah, because your body too big. Right, you have too much calcium, so you're calcitonin. You understand? To try to bring that calcium levels down, right? And that's it for secondary hyperparathyroidism. So wasn't that easy, guys? Everybody understand? If you all do it in points, I think that it would be better. So, well, for the ones that you not write it in an essay, and when you have it in point, you know that it goes through a flow. Just like with, yes, do the flow chart. Do you understand? So I'll just go through it one more time. I know it's 8 o'clock and I'll probably keeping back you guys some, going in your bed or going and study by yourself. But what the hell, they're studying with me. So I will just try to do it like point form, flow chart form, right? How is that? Now? Yeah. So I'll do it like flow chart in like a point form. So you all could just get it really quick, right? So vitamin D is digested, which is D1 and or synthesized in the skin, right? Then transported to the liver, which it is converted to ergocalciferol or calcidiol, also known as vitamin D2.
Hi.
Yes.
So I have a question, right?
Yeah.
So instead of doing it as an essay, we could do it as a point form too, or it has to be done as an essay.
You're doing it explaining. So it's not a matter you deal. It's not really, you will write points, obviously, you understand, but you just continue. It's the same thing. Just like you're writing points, you just continue.
So just saying hypothetically, if I do it as a point form, that is
Once you are flowing, no problem.
okay.
You understand? That's why I said like the flow chart. You understand? Once you're flowing, no problem because you explain everything that happened. But even though you're doing it in point form, it's not just vitamin D1 to D2 to D3, and you wouldn't get no marks for that. You understand? So you always still have to have a little explanation, although writing your points. You understand? So vitamin D1, which you get when you ingest, vitamin D, which is ingested, you understand, or synthesized from the violet ultra rays of the sun, right? It goes to the liver and converts to vitamin D2, which is calciferol or calcidiol, right? Then it from this vitamin D2, it is converted to vitamin D3, which is calcitriol, right? By a enzyme called 1-alpha hydroxylase. Then, but as kidney function declines, right, the conversion from D2 to D3, it gets affected. It is impaired. Right? It is impaired. So therefore we have a problem. No, we're still going in points. But if there's a calcium deficiency, because vitamin D3 is responsible for the absorption of calcium, right? And if we do not have this vitamin D3, because it is inhibited by chronic kidney disease. If we do not have this vitamin D3 because it is inhibited by, or it is affected, sorry, by chronic kidney disease, then we'll start to have a low amount of calcium, a low amount of calcium and a high amount of phosphorus, right? So when we have a decreased amount of calcium and a high amount of phosphorus, a message is sent to the hypothalamus in the brain, right? To secrete parathyroid releasing hormone. And this parathyroid releasing hormone goes to the anterior pituitary gland, and this pituitary gland releases parathyroid stimulating hormone. Now, remember, let me just go back a bit. Remember, a message is sent to release parathyroid hormone. You understand? But before we get the parathyroid hormone, the parathyroid releasing hormone comes first. You understand? So we have parathyroid releasing hormone. It goes to the anterior pituitary gland. You understand? And the pituitary gland then releases parathyroid stimulating hormone. Right? And when this parathyroid stimulating hormones, it goes to the parathyroid gland and stimulates the parathyroid gland, right? To release parathyroid hormone. So that's how we get parathyroid hormone. So now with a high level of phosphorus and a low level of calcium and the parathyroid hormone being released, you understand? Remember, the kidney levels continue to decrease because this person have chronic kidney disease. So with the continuous decrease, the situation with the vitamin D2 to D3 conversion, it gets worse, right? And with this worsening, then you continue to have low calcium and high phosphorus, and the brain continue to get this message to send out parathyroid hormone. You understand? So more parathyroid hormone and more parathyroid hormone is released, and this is called secondary hyperparathyroidism. You understand? So now, yes.
So the message is sent after the conversion of D2. And before it reaches to D3, the message is sent to the brain.
No. When the message is sent to the brain, the message is sent to the brain when you have chronic kidney disease and the conversion of D2 to D3 is not able to happen no more because the enzyme that does the enzyme that does convert the D2 to the D3 is affected, right? Which is the 1-alpha hydroxylase. When the kidneys is affected, the 1-alpha hydroxylase, it gets affected, this conversion. So when this 1-alpha hydroxylase enzyme gets affected, then the body would not be able to absorb calcium. You understand? Because you need that D3, which is calcitriol. You need that in order to absorb calcium. So your body starts to lack calcium. You understand? You have a low level of calcium because your body not able to absorb the calcium because you don't have that enzyme. You know? And that is what does it said when your body starts to lack the calcium, it get a message to your brain. Your brain now start to stay away, boy. Low calcium and high phosphorus. I need to let go some parathyroid hormone. You understand? Because something wrong. Yes, it's a lot of information to remember, but it's a matter of just, as you said, you could do it in your points, and you have to still remember what happens at each point and be able to remember what happens. Now you could write it in point for me, you get 5 marks. You know? Not the whole 10. If you're satisfied with that.
So I have a next question. Every time we do it and it's not in order, does that still count?
No.
Like
Because
my brain
you can't have 3 before 1, no. And you can't just try that. You have to write everything about it and how it happens. Okay. Because it's a cycle. So yeah, so even if let me say you start to explain secondary hyperparathyroidism happens, let me just say you say secondary hyperparathyroidism happens due to the increased stimulation at the parathyroid gland and continuous secretion of the parathyroid hormone. Okay, that is going to say nothing. But so how this end up, how you have increased stimulation at the parathyroid hormone, or why this gland increased just due to chronic kidney disease? What about the chronic kidney disease that stimulate this gland to make something called secondary hyperparathyroidism? And then remember, secondary hyperparathyroidism, it's called secondary hyperparathyroidism because something caused that. You understand? Because secondary hyperparathyroidism is the fact that you have an increase of parathyroid hormone in your blood. But why you have an increase in parathyroid hormone in your blood is because you have a decrease of calcium and an increase of phosphate. Why you have a decrease in calcium and you have an increase in phosphate? Because your vitamin D2 wasn't able to be converted to vitamin D3. And why your vitamin D2 wasn't able to be converted to vitamin D3? Because you have chronic kidney disease. So everything is a cycle, and once you're able to join everything together, no problem. You can write it in whatever fashion you want. As long as you're able to always bounce back to why this is so. So, Ms. Kusen, you understand?
Yes, ma'am.
I kind of hurt your head there.
I lost.
No, I don't know what page it is on the
been a while.
handout. What? Huh?
It's been a while since I actually studied my voice. So, yeah. I'm not
Well, let me tell you which page you have. I do not know, but on my page is page 94, but I think it have a handout mark chronic kidney disease and metabolism of bone calcium and phosphorus. Right? You all have that handout?
Yes, we do.
Right. So for the people that don't understand, I find this is the easiest. No, it had the other handout where I was talking about more metabolism, but I didn't use that. So somebody told me that it is page 25, right? Where Dr. Michael talk about it with what are osteoclasts, right? What are osteoclasts? Right down there after step 1, step 2, where he started to talk about, let us now look at the role of vitamin D, right? From let us now look at the role of vitamin D to the end of the page, which is on the other side, right? Talking about bone turnover disease. I want you all to take your time and read over that, right? Because that is everything that I just said. I just explained it in layman terms because the big words is not for all. And as I say, if you remember, vitamin D2, calcidiol, then vitamin D3, calcitriol. Always remember, vitamin D3 is calcitriol. I remember I buy the 3 and the 3, right? And I remember calcidiol because 2 is dose and D in dose, and calcidiol, it just makes sense with 2 and 3, right? If you do not want to remember, ogocalciferol.
Excuse me, somebody is there any way to know?
Yes, I Sarah Karen. I press and Mark joining for the longest while, and I don't know what's happening.
They say they about since 7.
It's only Mark joining. It didn't mark like admit or anything because I done a press admit a goodbye, and it just said joining, and that's it. And then nobody had there again after joining. So I thought the person joined. Yes, so I want you all to take your time and go through it, right? Read over that, and you all will pick back the same points that I saw. You all will get the words and the spelling of the words ergocalcidiol, ergocalcitriol. You will see where they talk about with the kidney being affected. It makes the D2 conversion to D3 harder because the enzyme is not produced. And I want you all to always remember that. Remember, the kidney the kidney have an important role to play with the balance of hormones and electrolytes and stuff like that. So, you know, always keep that in mind.
I said without water, that's right. From what you
Excuse?
said there. I said if I could
Excuse?
read what you said just right.
You could send me in a message. You want to read it now?
No, I couldn't hear it. Come on.
Excuse?
I will send it.
Okay, no problem. Yeah, so everybody ready for exam?
No, man.
A little bit, yeah. Well, not a little bit. I ready. It's just to remember this stuff.
Okay, I'll
Yeah,
give you
just
all a blight. I'll give you all a pass tonight. And anybody want help, they could message me anytime. Because I really some people
Tomorrow?
can't tell me. Today and tomorrow.
Okay, tomorrow, because I ready to pay my bill.
Yeah. So I'm sorry for keeping you all back so late, right? I didn't mean to keep back you all guys so late, but some students really wanted me to explain this, and
that bone.
I wanted to get it across.
I understand the bone better now.
Very nice. Thank you very much. I hope everybody understand the bone better.
Yeah, I had it in it, but just I was connecting two little pieces.
Okay.
With the
The story they gave her the one lady, that really helped.
Nice. Yeah, so you understand how it has happened. Yeah, and just be really sad. So, I mean, you all have to message me. Right now, my phone going mad, but um, yeah.
So we
Okay.
having a class tomorrow too?
That would be nice. Who keep in that class? I would love to join.
I thought was that you just said,
That's what I do in our class tomorrow. I want to join too.
I said that I am available all night tonight and all day tomorrow.
Oh,
Convenience
okay,
of
okay.
anyone.
Okay.
Um, so it had times that like when my students really needed the help, and I used to still consider sometimes doing an extra tutorial on the day before exams, but then some people used to go get it mixed up, so I stopped.
Yeah.
So if I feel generous tomorrow, I could put in a word for our next tutorial, and we could, for the students who really do understand, they can message me.
All right.
Okay?
Okay, miss. Thanks very much.
And they could never go over everything in one tutorial
True.
because it's too much.
Yeah, it's plenty.
That's why it have me. I am whole day always to talk to her, and nobody does message, and you know. But yes, we can go through some more other topics. So everybody enjoy your night.
See you, miss. Have a good one.
Yes, you too. Oh, wait. So some people send me the S1 drug dynamics, right? And no, it was good. But I just want to put across that you see we have drug dynamics, site receptors, and what was the last thing? You're adding in all, you're reading them, and it's like you're giving basic definitions of all, and that will help you make up your essay of drug dynamics, right? It's not really how chronic kidney disease affects drug dynamics, but it's just being able to explain drug dynamics on the whole, how drug works and how it works on the body and how it affects the body. Because that is what drug dynamics is. I just wanted to get that out there for anybody that need help with drug dynamics, message me.
Tomorrow, please God, I'll do that. Closing in on that drug. I'll go
Okay.
message you tomorrow. Yeah.
Okay, no problem.
Miss, excuse,
Yes.
dynamics. And it's just what they do Dr. Leisure,
What?
the drug dynamics.
It's
Yeah.
more or less, but
Isn't similar to what we did with Dr. Leisure.
I don't know what you are doing, Dr. Lesion.
it's the same. Mama, I know who's talking, but it's the same. But that's with this one where Dr. Michael wanted to tie in the agonist and the antagonist, and that is why he brought in the drug dynamic here.
No. Yes, he talk about agonists. How about now? Understand this, and the reason why I tell you all drug dynamics and I mix it up with agonists and antagonists. Yes, it have agonists and antagonists, and you can explain it within the drug dynamics. Nobody says no, but it's not a reason for explaining the agonist and the antagonist, because then it is a question talking about high blood pressure and what it would do if you get this person some pill and yeah, but that's not, I'm sure why I'm talking about that, but yeah. So yeah, your drug dynamics is not only agonist and antagonist, but you have to
No,
explain what drug dynamics is, right? Like
it's the same thing with what Dr. said.
just
Like
don't mix.
besides the second all of that.
Now I don't know what Dr. Lesion told you guys. My words will never be there, will never be theirs, and I just think about everything differently and write everything differently, right? But with drug
But it's
dynamics, especially.
drug dynamics
Okay,
is the
let me just,
drugs have to
before
body
anybody, if you
absorb.
want to log out, you all can log out, because I know some people tired or whatnot, right? But I just want to read this quick, right? This quick drug dynamics um as explanation, and we'll be done, right? So drug dynamics refer to what drugs do to our body. It also describes the therapeutic effects and the side effects of drugs and how drugs act on the body. Drugs are taken in many different ways. That is, swallowed, inhaled, injected, or absorbed through the skin. It enters the bloodstream, and the drugs then go to their target sites where they produce their intended effects. Some drugs are non-selective and some are selective. Non-selective drugs affect many different tissues and organs, while selective drugs affect mainly a organ or a system. Drugs know how to exert their effects by interacting with cells and substances such as enzymes. On the surface of most cells, there are different types of receptors, and receptors are molecules with a specific dimensional structure, which allow substances which fit precisely to attach to it. Receptors allow substances outside the cell to influence the activity of the cell, such as neurotransmitters and hormones. Drugs mimic these substances and use the receptors in the same way. Some drugs attach to one receptor, others attach to many, and that is how drug dynamics work.
Okay.
Because agonists and antagonists goes to receptors anyhow. But as I said, have a reason for the agonist. I did tell you do your example with the agonist and antagonist, but once you have the points, right? You get your marks. And um if they ask about, let's just say, a certain drug to raise the pressure, look at the drug, figure out whether it is an agonist or an antagonist, figure out whether it will help the patient or it wouldn't help the patient, because you all have scenarios coming. Exam don't ever get more easy, they just get more hard. The easiest, next easy exam from here, from this exam, will be peritoneal dialysis. That's just very easy because it's short points, right? But yeah, so I hope you all understood. Anybody need help? You all can message me. Enjoy your nights. I have kept you all over your time limit. I am very sorry. I apologize. Okay, Miss Prince, you can message me. Miss Nita, I think that's the name. You can also message me for any inquisitions. Okay.
Bye.
It's pronounced Nida.
My miss.
Nida.
Yes.
Sorry, I thought it was Nita. Sorry. I'm very
Okay.
sorry, Miss Hussein, Miss Nita Hussein. I'm sorry. So that's why I asked her to
Nida.
pronounce. Okay. Sorry. I'll get it better
Okay.
next.
No problem.
Nice.
Okay, good night, everybody.